Okay. But I would like shortly to introduce and your biography, which again, everyone can also find on our web page. So, you are a clinical psychologist specialized in trauma-related disorders, the director of the Center of Excellence for Psychotraumatology at the University of Constance in Germany, and your research projects are focused on multiple and complex traumatizations, as well as the transgenerational consequences of violence and neglect. There is much more to say, which everyone could see on our webpage, and I would like to stop here because I'm looking very much forward to your talk. You are going to go on with what Thomas started. You are going to tell us a little bit more about narrative exposure therapy and how also museums, who not take the whole life of a person, but only a little bit, even can do something good and contribute by doing just that and not more. So Maggie, the floor is yours.
Thank you, Katrin, for your very nice introduction. I'm excited to be here with all these historians, ethnologists, and anthropologists, and I will immediately share my screen so that everybody can see what is here. I think you can see my presentation, right? I think this was a misunderstanding. I'm really sorry, Katrin. I just meant that it's difficult to send the slides. So that's why we had this confusion. You see a lifeline here. Our lifeline is the timeline of our developmental trajectories, where we go through very bad events and very good events. I will get to this importance of the specific events that build our memory during my talk now. If you need to write to me, please do so. This is my email. I'll send you all the material you want to have from me. Just bear with us momentarily. We are dealing with a lot of requests for supervision and training and help for the high influx of refugees. When it comes to narration, I just read a blog recently, and I was really impressed about museums' work because they are really aware of narratives. This is the Australian Museum in Sydney, and it says they were really quoting some important resources on narration and the work of storytelling. Storytelling was the real work of museums. So this is what we do as therapists, because stories can be a powerful tool for museums to bring visitors. And even it says that it's appropriate to the work of a museum that we are storytellers. I think this is really important, that it's over time that you preserve in your work for generations to come what has happened, and that everybody can engage with what you're showing. The speechless terror, excuse me for the graphic image. This is from Xavier Tarot, a Berlin artist. This is how we call trauma, and narration and trauma on the first glimpse don't go well together. How can a traumatized person speak? Everything that's remembered is strange, it's frightening, it's overwhelming, it's what the psychologists say, it's ego alien even. And people think that they don't have words, and if they would have them, that the listener couldn't understand. So the only clinical disturbance where you have avoidance as a major symptomatology. Thomas has just explained how these memories break apart. And this is because when multiple event happens, time and place cannot be co-activated, since these representations inhibit each other. You can only be at one place and not at the other, but you again and again, you heat up your memory about these associative elements. So the context gets lost, and as a consequence, we relive what we have gone through. There's a strong biology behind surviving. And to understand this, I just show you 2 slides here. When we have to run and flee and we are really frightened and aroused, We first try to flee, and then we might try to fight. So we are highly emotional, but on the way up our arousal, we are already losing functions. We can't think properly anymore. We can't perceive information properly anymore. We are numb, and we are more and more anxious and just on an automatic mode. On the highest point of alertness, we are in a fright stage. Psychophysiologists call this stage tonic immobility. So you freeze. Once the threat is overwhelming, you can't move anymore. You're really alert, you have a high heart rate, but you can't behave anymore. You can't flee or fight. And this is a very good idea from the evolution, given us from the evolution, to not respond to whatever's there anymore, just play dead. But you can't scream anymore, and you can't terminate. Often you can't terminate this response yourself. So you're dependent on your environment to help you get out of this stage. And the last stage really in survivors we see is the flaccid immobility. So they're going in a flag state, they're giving up, and the heart rate is going finally down, and they can have a syncope and drop to the ground. So it's quite a heavy response, and this is why we are not astonished that people can't remember what they have gone through, or they only remember in fragments. This is a girl who has been detained in the Iraq war by the IS. So the whole defense cascade goes like this. You really arouse, you go into a fright stage, and finally you will collapse. And in this area, when we reach arousal to this point and fear and horror to this point, then we really are in danger to develop a trauma spectrum disorder later on. People relive not only their events involuntarily, but their reality is the trauma. It's much more real what happens in your brain, what happens in the representations of the brain than in the here and now. The here and now isn't very important. It seems to be unreal. It seems to be a dream. They are not out of their terror. Catherine perhaps has asked me about the doubts we should have when we approach trauma material, when we approach trauma memories. Therapists have many doubts. What it does to their, whether it harms their patients when they confront them with those memories. They are worried of flooding or triggering the trauma memories. Do we need to control that better? Do we need a stabilization? How long are we not allowed to talk about? But this takes away, of course, competency and control from the survivor, because they are actually the ones who should be in charge of decision making when they want to speak, to whom they want to speak. So this type of collective and common avoidance we all develop in the sphere of trauma can lead to serious mistakes dealing with each other, and to a type of over-identification that is really more a pittiness than help. We like to encourage therapists and helpers to encourage survivors to talk about their past. This is a picture from Finland, from the group around Kirsi Peltonen. They do narrative exposure therapy research. And here is a young man, a young refugee, holding his stones and flowers in his hands. The stones for the very difficult moments, for the traumatic moments, for the losses, and the flowers for the beautiful moments, for the people who loved us in our biography, for the moments we really did well, we were succeeding, we were proud of us, we had animals we liked, and so on. So this is a pile of highly arousing specific events that has no time and place. It's all intermingled. I would like to walk you through the pillars of narrative exposure therapy And by doing that, you can build your own trauma therapy, because this is the most important ingredients you need. The first thing you really need to rehabilitate traumatized minds is trauma-focused work. Trauma-focused work means you're reconstructing the fragmented memories into a coherent narrative. This is a very important step, and it needs some guidance. The next pillar that is really important to be aware of is to use a lifespan approach. There's not only one trauma, it's typically a building block of traumatic and stressful events in our life, and they are all connected to each other, together with the positive moments, with the moments we could survive something we did right, otherwise we wouldn't have survived. So childhood trauma may be from your childhood, but typically it's from your parents' childhood, and they experienced interpersonal trauma that they carry on to the next generation. Childhood trauma never ends in childhood. It never even ends at the individual end of our life. It resonates down generations, as we've just heard. We want to work with whatever's there in a memory of a person and all the interconnected life events someone has gone through. So it doesn't make sense to just pick one. The clinicians call it index trauma, because you couldn't even decide which one is the worst one. This doesn't make sense. You are a whole personality, not just one traumatic incident. So you want to have a biography work that includes in chronological order all the important events of your life. You want to work through them, how they appear on your timeline. You want to place them back in time and space so that they don't intrude anymore involuntarily. So story, as you can see, building a story is a very important point. One of the most important things we discussed in the 70s is it actually okay to speak about trauma spectrum disorders as a pathology? Because survivors are not sick, the system is sick, the war is sick, so torture is wrong. The survivor isn't wrong and isn't pathologic. But it is a great amount of suffering, and there is pathology around it. Just what you want to do is you want to treat the pathology, you want to reduce the symptoms, to allow remittance of symptoms, to make people healthier in their brain and mind and in their body, because trauma survivors often suffer from many physical problems, somatic problems. But in the same time, you would really want to make sure for advocacy, and you're really a listener to the person who gives testimony. And one of the last things is it needs to be a cross-cultural approach. It needs to be for people to include everybody and on a low as a low threshold intervention. Like you don't want to have high difficulties to join, like formal education or even formal Western education, reading and writing, doing homeworks. All of that is not realistic on the grades scope. If you look at the billions of people who are really 2 billion of people are living in poverty and are targeted by war and are under immense pressure of violations, intimate, like partner violence, there is family violence, there is organized violence, and of course there is sexual violence in a great amount. So it doesn't make sense to work with just professionals. You need to have a trauma treatment that is brief and that can be put into step care approaches like cascade systems of care, and you have to have task shifting to include lay personnel, trained lay personnel that helps with the scope of trauma. Now, what's left? One thing that is truly human is our oral history and our way to connect to other humans and tell them our stories. So we build our self-identity, our past, and our meaning making via storytelling and narration. That's clear. Now, how to approach? How would you best approach trauma material so that you don't harm your respondent? I think this is one of the pressing issues here. You never want to invite a trauma survivor, a traumatized survivor, I should say, to tell their trauma stories in an unstructured way. You always want to approach trauma material very careful and in a structured manner. You want to behave predictably, and you want to use the 3S policy, as we call it. The first thing when you're in front of a respondent is you want to settle in with yourself. You attend to yourself first and make sure that your mind is calm, that you're not nervous, and you're not just using a strategy. You have to be really fully present and open up to what we're going to hear. So what you really do is first make sure for the right energy and then use your strategy. The next thing is what I always teach students is speak slow. People who are nervous, who are anxious, and who go back to their trauma scenes, they really have a hard time concentrating. They can't attend to what you're saying because it's just not so important to them. To them, still surviving, and this impending threat in their brain is much more important. So you want to speak slow. You want to speak very clear, make short sentences and loud enough. Because, as I showed you a moment before, when the anxiety goes up, people have a difficult time perceiving sensory information. They can't hear well, they can't see well, they feel numb on their skin. So be sure you speak loud enough, but calm. And then if you really want to make sure that people attend to you, use their name. If they're acutely traumatized, use their first name. We typically listen much better to our first name than to the family name. So important is a face-to-face interview. That's the first step of narrative exposure therapy. It is the interview when we ask about specific events. That's the way everybody can talk about their trauma, not full sentences, not the whole story yet, but just saying yes or no to a list of events that a person can encounter. Typically, we have accidents, we have catastrophes, we have violations like family violence, sexual violence, and so on. We have events like torture, like war, and seeing horrific scenes, and so on. When you look at the list, this is a list that you can ask, and always stay on the contextual side. You don't want to hear the story behind that yet. You only ask, have you ever survived a natural disaster? Was this happening to you? Did you witness someone confronted with this event? Have you heard about that the loved one survived this event, or was it part of your job as a helper, as a fire worker, as a paramedic? In this way, you can contact the first time trauma material in a very structured and controlled manner. And of course, your memory starts warming up. If you bring in a list, it's much more normalization, because you can always tell this is a list from other survivors that has been put together, and we just go through whether you have survived one of the events on the list. As a trained layperson, you can't do a diagnostic interview, but you can do a screening interview. This is made for lay people who want to help in the task shifting. So you can ask for symptoms. And if you ask these symptoms, according to that screener, for example, this is the refugee health screener, a very well-validated instrument, and then ask how people cope with what they have gone through, and you sum up. If the score is greater than 12 or the thermometer of extreme stress or no stress is above 5, then you want to refer this person to a more professional mental health service. So at this stage, you can do this assisted interview with a screener, with the help of a screening instrument. Step 2, what we do in trauma treatment, in narrative exposure, is the lifeline, the biographical overview along the timeline. Here you can see that we place our symbols along the timeline. Now we are putting the events we have found on our list on the timeline and see them in chronological order. What builds memory are our high arousing moments. Be it the car accident, be it the birth of the child, be it a rape in the park. We remember important things, and which things are important? Those who cause us to experience a lot of emotions and high physiological arousal. So this life goes up and down, and the high arousing moments, they get a name, they get a heading, a label, where it happened, when it happened, and how you call it if it was a chapter of a book. Here we have an example from a study of intensive care survivors. We are seeing more now in times of COVID. So you see this woman had already a difficult childhood. It wasn't only the serious car accident that led to the intensive care unit. There is already in the childhood, there is illnesses, there is being beaten, and then there is positive events, and then a rape, and then a robbery, and a marriage. So we have a lot of positive and negative events here, and only the final one is then the intensive care unit. So in this way, we can look at our lives, but still as an overview. This is still not going into detail. It's just an overview, but with the positive events now too. And now, in the final and most important step, we start the narration from birth and go and work through these events. Once we have worked through and narrated an event in great detail, next session we do a rereading. The therapist writes down the story and gives it back to the narrator, and together they find more detail. They read through whether it's right, and at this stage they can reflect on this younger person, on me being a younger person experiencing this. So we go through all the important events in a chronological order. Typically we deal with one big event in one double session. If you're going in depth and you want to work in a very robust way during the narration of a specific event, you want to start with sensory perceptions. Let me walk you through. Like, what did you perceive? I was in the kitchen cooking, and all of a sudden I had this smell in my nose. This smell, what did you think about it? Oh, I was thinking, oh my goodness, my children are in the barn. I hope they didn't set the place on fire. And only if this cognition is there, you get fearful. And this is the emotion that follows this cognition is fear. And then the body responds. And finally, you interpret all of these levels you have already talked through. You make an interpretation and realize that you're so anxious and so fearful because you think your children are in danger and you have to run and rescue them. So always start with a sensory perception, like the door is, there is a banging at the door, and you open it. In front of the door, there is this soldier in a green uniform. What is your thought? How is the emotion? And this emotion is always a precursor for your action, and then follows a physiological response that you can find in your body, and the meaning for this specific moment. So that's a quite robust way to work through moment by moment, work through hot memory moments. The most important thing, if you have a trauma story told in that way, is to all time contrast it with the here and now, because the respondent telling the story will experience the same emotions, the same bodily responses, and even the same meaning types of context again and again. So what you see here mirrors during your narration. And I think this is what makes us so afraid of narrations, because we know exactly the person feels drawn back, like in the time machine, is a little bit back. And this is not what we want to see. We are thinking about the past, we're talking about it, we're not going there. So your role is really to keep the person in the here and now and just experiencing the past on these levels in a way that they're able to narrate, to talk about it. Person should always be able to talk about it, and for that, to support that, you help contrasting. So what we typically do is we go back and forth in these moments in a pendulum motion, like you talk about that your breathing was difficult at the time during the traumatic incident. And then you come back to the therapy room and you ask the narrator, how is your breathing now? Whew, yeah, it's just a little bit as it was then. Okay, how are your thoughts? How are your emotions? And then you go back again and keep narrating the story. In this way, you have a good contrast between the two settings during your imaginary exposure, and you can really then come to the moment of exposure, like the Latin word for getting out of this posture of being traumatized, that the survivor more and more is convinced to be out of the past. So you advance the narrative process in this way and keep narrating in this way. After the session, the therapist writes the transcript, and the next session begins with a rereading of the transcript from last time. Might be that it still contains a lot of emotions and anxiety. Then you need to go back once again and do it in more detail, support the narration further, write it up again and reread it a second time. The testimony that is furnished by doing this is really validating for the narrator, because the therapist makes the effort to write the life story up and brings it back. So it means a lot to many of the survivors, and it makes sure that the narrator is in control of what is written there. And even if people can't read and write, make sure you translate every little bit and write it up in an egocentric way. The last session, I owe this picture from our Brazilian narrative exposure therapy team. This picture is done by Janine Narok. In the last session, we give the chance for hopes and wishes for the future. So this lifeline ends with an outlook into the future of development. And here you can see how you would do your treatment. Typically, this is a short-term treatment. We use like 10 double sessions to go from the checklist, specific events, to the lifeline. This is one double session, and then the whole narrative process and the handing over of the testimony. I always finish my presentations since more than 20 years with a quote from survivors, because our NGO is Victims' Voice, VIVO, and I think they should have the last word, not other people. Let me try and see whether I can. Yeah. Can you hear that? Okay, let's try again.
All my adult life, since I began my life as an author or as a teacher, I always try to listen to the victim. In other words, if I remain silent, I may help my own soul, but because I do not help other people, I poison my soul. Silence never helps the victim. It only helps the victimizer. Faith?
Yeah. I think this is someone who really wrote about his experiences, and this is one of the most important messages that we can pass on. Silence never helps the victim. If you want to read up why it's so important to reconstruct the autobiographic narration, there is a lot of work done, and there's a lot of evidence-based work. This is just a list compiled how important testifying is, and testifying in the right way. I think one aspect I didn't talk about, and it's really more for psychotherapists, is the compassionate and respectful care repairs attachment wounds. Most of our survivors didn't only survive natural disasters, but interpersonal violence. Yeah. I hope in your work with narrations, in your historian and ethnology and anthropology work, you pick up on the signals from the past. This is refugees at the Djibouti shore trying to find the signal for connecting with their loved ones, and this signals from the past, as Thomas showed clearly, they really reflect into the future. You do the work of acquisition, of recording. Museums do preservation. They do research and interpretation. They do exhibits and education. That's all I could find. And this is very similar to what we do. Maybe we don't do exhibitions so often, but all the rest of this is our common ground. And I think we should really use it to work more closely together. Thank you very much.
Thank you very, very much, Maggie. This was very interesting. And I was writing a lot of questions here and asking myself a lot of questions. Unfortunately, the reactions of the participants, and that's a challenge when we are working with this kind of digital presentation. I would like to ask all of you who have listened to this very interesting talk to come forth with your questions. And while you do so, I will start with mine. Maggie, maybe you can stop sharing your screen. It would be easier for us. Thank you. I see we have the first person raising their hands. Maria, could you help me to give Ingeborg the speech? Maybe she can ask directly. Okay, while we are trying to figure it out, I have the first question, maybe, while we are working on the hand raising issue. If I can give you some idea about how we have worked in our project with traumatic, let's say war-related experiences. We invite, not addressing by someone directly, but we invite by, for example, having an announcement in the newspapers. We would like to work on the Second World War. I just give you an example in Norway. Are there any time witnesses here who might help us understand what happened in this area? We would like to document historical events, and we are interested in your personal narratives. Someone is coming to us, willing to talk to us. We invite them to a talk. We have prepared a semi-structured interview guide. We are in the moment. We follow many of your 3 S's. We are in the moment, we are prepared. Of course, we are afraid that we might re-traumatize, but we have our semi-structured interview guide. We start with questions. We end normally with positive questions, that we don't leave the interview situation in a very bad mood, if you want to say it like that. And often we summarize the interview afterwards. We give it to the person, we ask for input, and it goes forth and back until the informant is satisfied with the presentation or with the narrative, and then we get a letter of content that we allow to use it in exhibition, in a book, and so on. Mm-hmm. So many of these things we do, I think, are not too bad. Recording, if I look at what you have said, but I have several questions here, because you were very much stressing that we should look at the whole life, because traumas build on each other. So if there is a traumatic experience, which often you can find in war-related situations, we have to look at the whole lifespan. So my question would be, with the approach you just have heard, we as a historian are only in one case, for example, interested in the Second World War or another historical event which was important for many people. Is this okay? Can we leave the rest out, or should we always ask birth to death? And our semi-structured interview guide should be more like the life event checklist. What would you say? This approach, it's not psychological, it's not your way to do it, but where do you see the obstacles and where do you see the positive effects of concentrating only on a little part? And would you, the last question then, of course, would you recommend us to change our approach a little bit from your point of view?
Mm-hmm. It depends a bit, Catherine, what you want to achieve. We want to heal or start a healing process, obviously. We do therapeutic interventions. And I think this is the difference. You want to know a little bit about your respondent. Because if people are suffering, like, let's say, from a post-traumatic stress disorder, then it's really difficult just take one piece of their hot memory and work on it. Because these people have a hard time afterwards. They will be really in their involuntary reliving their trauma. They will be out there, they might dissociate, they might repeat some of the biological responses I explained to you. So if you are working with respondents who are acutely or post-traumatically suffering from disorders, you should get mental health support probably. And you want to make sure that these people are well taken care of, that it's within a context of care. They can still give their testimony, but they should have a little bit more support. And they should be very good informed about what you're doing, why you're doing it, so that you give them full control. I don't say that everybody has to have treatment because it's their choice, it's not our choice, but you should at least explain that there is maybe a point at which it's really more beneficial to seek treatment. Okay, if you work with people who've gone through traumatic incidents, but they don't suffer from a trauma spectrum disorder, when you work with them and you talk to them, then of course it's a different situation. Then they are not patients, or they're not so vulnerable. They can make a really informed choice by themselves and say, okay, I participate in this or I don't. So I would, to answer your question, I would distinguish between people who acutely or post-traumatically currently suffer with symptoms, and two survivors who are really they did survive a lot, but they took away more growth than pathology, and they're doing fine. Their social and occupational functioning, then it's perfectly okay to go ahead.
Automatically, I see your husband raised his hand, so I will give the floor to Thomas. But before I do so, of course, my first statement would be, it's very difficult for me, who is not a professional in your field, to see how traumatized a person is.
Yeah, that's why these screeners are really good. If you say, yes, if you don't mind filling this in, or even I asked you, it's even, we did it with translators. They are not clinical psychologists, they use the screener and just ask the questions. And these are screeners that are really going well. They're really allowed by all groups I mean, there's different schools of trauma and different schools of trauma treatments, but they all have a common ground, and these screeners are allowed by all of them for lay personnel. So I can send you more, and I can send your audience more if they're interested. So there are a few simple questions, and then you count the numbers together. And if they succeed, if they're higher, like a threshold, then you know this is maybe someone who should see mental health support first and then decide to work with us. So you would be on the safer side.
That's actually very interesting. So what you are saying is change your routines a little bit, make it a little bit safer when working on these difficult issues. Use a live event checklist, which has been used by many professions, is very appropriate. So use it in addition to check it out. That's a good idea. We will have that in the back of our minds in the future. A last comment. Interesting enough, we have had quite some informants over the years who told us the good thing with you are that you are no psychologist, because I don't have to get the stamp of being ill.
Yeah.
Historians, and I would like to contribute to history.
Yeah. Yeah.
And by that, I felt, because we are, of course, many working with this, we felt that it's also maybe this is a question to you, that the informants or the patient, let's say informant, has the choice to say, okay, I'm not sick, I'm not ill, but I have something to tell, which might contribute to others recognizing themselves in my story. Maybe I can contribute to something bigger. Maybe it's also good for me to talk. Maybe this is because, of course, you said your goal is to heal. Yeah. I say this is my personal perspective, but I think many of my colleagues would share that. Of course, healing is our purpose, but maybe not healing one person and one individual, but healing
on a collective level.
Yes, messed up societies where people are not heard and seen because of something.
Yeah, it's interesting that this is the discussion we had since decades, that it's labeling and stigmatizing to call people pathologic who have survived such horrific situations. On the other hand, many of the survivors don't know what they run into. They only realize later that it might be like overwhelming for them. So maybe you do what you do so successfully, and then you have a good referral system or some understanding psychologist that's by your side and that might offer some psychoeducation at least to give the person information if they're confused what's happening now to them.
Thank you very much. Thomas took down his hand again, so I am allowed to ask more questions. This is very good. When we are in a situation with the informant and the informant is sharing information which triggers something in us, museums professionals or researchers, which we were not prepared about. So maybe we went into this knowing or thinking that this could be handled. Then you are in a situation, you are sitting there one-to-one, and something what the other person says triggers something in you which make you understand that I am not able to react properly here because it just breaks me down here now.
It's okay, it happens all the time. We're humans. Either the story is so terrible or it has something to do with our lives, typically. Or we are not in a good condition, like we're already a bit sick, something like that. So we have many reasons why trauma can hit us, a trauma of other, like secondary, vicariously. What we say, if our our students and new trauma therapists start hearing these narrations, we say if both fall to the ground, the therapist should get up first. So I don't know, in your setting, who gets up first? Probably the survivor, because they already know how to pull themselves together But it happens all the time. The only thing is you shouldn't be afraid of such a response. Otherwise, you start yourself to avoid. And avoidance always leads to chronification. So if you get hit by some topic and you really feel bad and you feel that this is painful or you want to tear up, that's perfectly okay. Don't get afraid of what's happening there. This is a normal reaction to unnormal events. That's how we call it.
Thank you very much. I still don't see any questions, so I'm allowed, luckily, one, because we are going to have a coffee break in a second. Sometimes we are having speeches and lectures in front of the public, many people in the room. If it's not digitally, now room to room, we are getting back after the pandemic to this. And when talking about historical events, which have been traumatic to some, we have experienced that in the audience, in the public, 40, 60, 80 people, someone raises and tells their own story in this public situation. I have asked the question I ask you now. I've asked it before and got a very good answer. So now I just want an answer from you in addition to build it. It happened just 6 weeks ago, me asking or telling about Germany actually, and how many children of war are traumatized still or have a reduced life quality, and how much what happened then, they didn't understand how traumatic it was actually. Mm-hmm. The audience raises and tells a story which must have been extremely traumatic in a very funny way. Mm-hmm. That the person is telling in front of an audience a story about death, about murder, about really, really heavy stuff, smiling, joking, telling it as the best story ever. Mm-hmm. You are standing in front, not educated to handle such a situation because you have an audience to react to, and you have a person which you don't know to react to. Mm-hmm. My question is, the very last, in such a situation, when you as a person, as a lecturer in front, realize that there is a mismatch here between the face, the voice, the funny telling of this 80-year-old person and the content of the story, do you have any immediate tips how to react?
You don't want this person to lose face, obviously. And you don't want to make things worse. We call it the party version. People are disconnected from their feelings that underlie there. I wouldn't try and be therapeutic in that moment, and I wouldn't address that discrepancy. I think an honest reaction. Well, for us, it's rule number 1 is transparency. There is no such thing like a hidden agenda. It's so important for trauma survivors because they had so much abuse that you want to be honest. So you say, wow, you are really dealing with this stuff in a very funny way. You're trying to joke and you're cheering us up. You're very, very strong. You've survived this and you're very strong that you can make jokes. For me, it's hard to hear. It causes suffering. So you share your response because it's difficult, it's hard, it's terrible things, he said, obviously. You feel bad that everybody had to hear it, so you express how you feel, but you speak from your own you speak about your own reaction, and then you validate the other person. That's it. I wouldn't do anything else. So this person will go home and know next time what it does to other people without feeling of being offended or losing face.
Thank you very much. And then in good German, how can I say it? Manner, it's 10 minutes to 4, and we are on the second, there we should be now. So thank you very, very much to both you, Maggie and Thomas, for your presentations, the first presentations, and to all participants. We are going to have a 10-minute break now, because before we are going over to Trisha. So I'm looking very much forward to seeing you all again. in 10 minutes from now. Thank you.
Thank you. Bye.